Okay, guys, welcome. This is a really special session. We are delighted today to have our good friend Irene Sansano from Spain, from Barcelona, to join us today. She's a really good lung pathologist and shares our interest in non-neoplastic lung disease. There are very few of us like that in the world who like to do interstitial lung. But Irene likes to do both lung pathology of all kinds, as well as is in a really big transplant center. So she sees a lot of transplant lung disease. And of course, Matt Cicchini, Cicchini, he says to say that. Cicchini, Cicchini.
Yeah.
Cicchini is also with us. And we're all going to
Thanks,
talk about
Sanjay.
one of my favorite topics, which is a smoking related interstitial lung disease. But we're going to talk about all the findings that we see there and all the controversies that happen around terminology. But we are going to pretty much center the discussion around DIP and that term, and how good that term is for describing these diseases. So welcome, Irene. We're going to start off with one of Irene's cases. Welcome to our informal chat session, Irene. This is
Yeah.
going to be just totally informal, okay? So don't worry about say anything you want. It's everything goes.
Hi, thank you. I'm so happy to participate. I'm such a fan of this series, and today I'm here. And thank you both to let me do it.
Welcome.
Welcome.
I brought some cases that I would like to show with you.
Great.
And this is the first one. In this first case, the patient is a female. She is 63 years old. She's a smoker, and she has an image. She has a CT. Well, she had an incipient interstitial pneumopathy. It's an incidental finding. In the CT, she's said to have subpleural reticulation.
These are cryobiopsies, right?
Yes.
These are wonderful cryobiopsies.
Yeah.
These are the cryobiopsies. It happens, I think the cryobiopsies are best when the patient has very little illness.
Okay.
Because when the patient has a lot of fibrosis, it's difficult to, it's an impression that I have. Yeah. It's difficult to pull tissue, but in this case, as you see, the fragments are big. Oh.
Can I ask you a question, Irene, about your the practice at your institution? So yes. In your institution, have you moved completely to cryobiopsy, or do you ever do just a conventional transbronchial biopsy?
We do conventional transbronchial biopsies in patients that don't allow a cryobiopsy, in patients that are severe.
I see.
But for most things, even for cancer, they do cryobiopsies. Wow. We get big pieces.
Wow.
I try to measure this one. This is a big one.
Yes, very different than ours. Matt, is it? Do you guys do cryobiopsy for everything like that, or how?
No, here in Canada, we used to do some cryobiopsies, but we're not currently doing any cryobiopsies actually, and it's all transbronchial biopsies or surgical lung biopsies.
Yeah, it might be a Europe versus North America thing, the cryobiopsy.
We don't do much surgical lung biopsies.
Oh, okay.
Oh, interesting. Yeah. Okay.
Then you probably are surprised because this is not lung.
Yes, there's a kidney over there, right? Yeah.
We agree in this. This is
we agree.
There's consensus.
That's the only thing that lung pathologists agree on is kidney pathology.
We use we use cassettes that have little holes that have six holes, and we put the different pieces in each of these. Then I know where this piece, which specific segment this piece is.
Okay.
For what? For nothing. It's not very useful, but it allowed me to show off sometimes, like saying, I think there is an infarction in segment 7, an infarct in segment 7 or something.
Oh, cool.
Look at this! You've got an interlobular septum in a cryobiopsy. Isn't that amazing?
That's the
It's
what
Like
I
amazing.
mini
wanted to
surgical
say.
biopsy. Amazing, amazing.
This cryobiopsy is not only big, it's well expanded. It has all the things that you want to see. It has you see my arrow, yes.
Yeah.
It has a bronchioli and it has a septum here.
Yeah, it's lovely.
It's a lovely one. What do I see here? Well, I see that the alveoli are big. I'm not sure here if it's a little of artifact, but for the distribution, I'm pretty sure it has some emphysema
Yes.
because, well, the distribution of it makes it
Yes.
real.
Can I stop you for a second, Irene, and ask you a question?
Yes.
So I find for emphysema is of all the things, that is the thing I find the hardest actually, especially mild forms of emphysema. I find it is not easy to be sure that something is emphysematous. If something is severe, it's pretty easy, right? Like if they're so big and so distorted,
Yeah.
or the spaces are so big and there's so much variation between the normal and abnormal that it's easy. But in a case like this, I felt just like you. When I saw it, I thought that's emphysema. But I'm like, could I be wrong? In cases like that, my practice is I try to go back to the CT and see if they also saw emphysema and sort of confirm that.
Yeah.
And if they didn't, then I feel a little hesitant about calling milder forms of emphysema. What do you guys think about that?
I completely agree. This is what happens. I think that when you see the distribution, the nice distribution where the big alveoli next to the airway and the small, it makes you more comfortable with it. But I absolutely agree with what you said.
I agree completely as well. I think the CT scan is the best thing for picking up the amount of emphysema, and so I always take a look at that as well.
Yeah. Can I ask you one more question? Sorry, I'm getting off track. But let me ask both of you, okay? So there is this so-called centrilobular emphysema, right?
Yeah.
I want to ask you guys, have you ever diagnosed panlobular emphysema without knowing that the patient has alpha-1 antitrypsin deficiency? So you don't know the history and you go, that's pan-acinar emphysema, alpha-1 antitrypsin.
Only on explant, looking at the entire lung and the distribution of it, that it wasn't kind of more apical based, and it was kind of a very diffuse process.
So let me ask you, Matt, on a case like that, you think it's panlobular based on the histology. What if it didn't turn out to be alpha-1 antitrypsin? What would you do then?
Well, then I probably would back away. But I think you'd look at other causes to make sure there's not something funny going on of why they have emphysema, right?
Yeah.
If it was everything fit, like if it was a smoker and everything, then I think I would then probably back down. But
and would it be off base to say that's probably happened once in your career, that you looked at that and said panlobular and you didn't know the history?
Yeah, probably, yeah.
Yeah, Irene, have you done it ever? Like a pan?
I never say, I don't have this problem because I never say centrilobular or panlobular. I always say emphysema. I think image is better for that, and they don't perform the biopsies for us to say emphysema. They already know the patient has emphysema.
Yes. Sorry for the interruption.
No, it's totally perfect. Your questions are interesting. And well, I said I think the biopsy has emphysema, and I think the interstitium is normal. Maybe has some inflammation, but not much. The thick of the thing is normal. I can see also some bronchial metaplasia here. And I see not in an airspace, I see not many airspace macrophages, but some. I see inflammation in the bronchioli.
Yeah.
I see anthracosis. And here, for example, it's too dark to see the golden pigment, but I think in other areas we are going to see it better. It's a golden pigment with little dots. The
Although it
Airspace,
doesn't project too well on the screen, but I can see that it's pigmented, very
Yeah.
light.
And so maybe for the listeners, we can describe what that pigment signifies.
Yeah. So Irene, what you're saying is this is the smoker's kind of pigment, right? Like very light brown pigment that's classically described in smokers. Yeah.
despite in some patients, the pneumologists say they have never smoked, we believe that this pigment is unlike anthracosis that I find in many patients, smokers are not. This pigment, I think, is very specific of smoking.
Yeah.
Yes. Can I
It-
make another comment here? One more comment about this. So because you brought it up, Irene, about the never smokers and the RB.
Totally.
So I think actually that's not that uncommon. Like in the Katzenstein, there's a paper by Freg and Katzenstein, which is the classic paper on this thing, on whether respiratory bronchiolitis can be seen in never smokers. And in their series, I think there were only 2 or 3 that were never smokers and had RB. But in my experience, I find it more maybe I'm not as good as her at picking it up, you know. But when I pick up RB, it's not uncommon that the patient turns out to be a never smoker. And I find that that happens more at the subtle end of the thing, you know, when there are only a few and the pigment is kind of iffy. And I'm saying, well, maybe this is RB. That's when the patients turn out to be never smokers. The more heavy ones, you know, where it's very clear cut and the pigment is everywhere, they are almost always smokers. So maybe, I don't know, can you guys talk about that thing a little bit, like your experience with how often your RB turns out to be never smokers?
I'm not sure because the pneumologist says the patient is not a smoker, but I think maybe people lie a little bit or they were former smokers. Some pneumologists think not smokers, but the
Secondhand
secondary smokers. Do you know what I mean?
Yes.
That it could be. I find difficult to that people that don't actively smoke have this pigment, but maybe I have no idea.
Yeah, Matt?
Yeah, I agree the same. I think most of the times I see it in smokers, and I think secondhand smoke can be a component of it as well. And
Yes.
if they're likely, even if they're non-smokers, maybe they live with someone who's a smoker or they're around with someone who's a smoker, which I think can be also contribute to some of the cases.
Yeah, my feeling about that is, you know, there are clearly degrees of how much you can have secondhand smoke, right? There's one thing where you're both sitting in a room and your partner is like constantly smoking all day long and you're immersed in that environment. Maybe you get a little bit of exposure from there. But all other minor degrees of secondhand smoke, I cannot see how that would lead to the same degree of exposure as actually inhaling the smoke from your own cigarette into your lungs. Like I feel that there's like a difference between a few drops of water from a tap and like inhaling a river into your lungs. You know, it's that kind of a difference.
Yeah, no,
There must be. Sorry.
No, go ahead.
No, that there are different degrees of smokers and different degrees of secondhand smokers also.
Yeah, and I think another thing to point out is the different, like this is the pigment you get from cigarette smoke, but I find that in patients who utilize marijuana or cannabis, the pigment looks a little bit different. It tends to be a little bit chunkier and darker brown in color, and I find that pigment can sometimes be a little bit more challenging to distinguish between hemosiderin. I think there's a little bit more of an overlap, but I find the most useful thing there is the hemosiderin has this more of a golden yellow color compared to the dark brown color that you see in the cannabis smoke.
Yes.
Haven't you found that this pigment that you said about smoking marijuana, it's more prominent in pneumothorax specimens?
Yes,
it is.
There's actually an association between marijuana use and increase in pneumothorax. And part of it is thought to be because of the different ways that people utilize marijuana. They tend to perform breath holding maneuvers, like Valsalva type maneuvers, and so that increases the pressure, and then it gets the material out to the more peripheral airways that could theoretically increase your risk of pneumothorax. And so that's the kind of mechanistic thought behind why there's more pneumothorax in the cannabis.
Yes. So can I summarize, at least between the three of us, there's agreement on one point, right? There's agreement that when in smokers, there's accumulation of pigmented macrophages within the air spaces. Everybody agrees with that, right?
Yeah.
So there's some agreement, right?
Definitely.
Between pulmonary pathologists.
So I have a question though. So what do you call this case? Do you call it RB or do you call it pigmented alveolar macrophages?
I called this emphysema with airspace, with pigmented macrophages.
Yes, so and I used to do like what we always did traditionally, emphysema and respiratory bronchiolitis. That I used to do that. Since our paper came out, I switched terminology, and now I say pigmented airspace macrophages. And the reason for that is, Matt. So Irene, can you go down to that collection of macrophages that you were just showing? Just a little bit higher. And just come out of like slightly lower, Mac, slightly lower. So because I want to just highlight the distribution here.
Mm.
So Matt, would you agree with me that this is not a classic respiratory bronchiole?
I would agree.
Right? I mean, you want to see the partner artery and the little continuation with the alveoli.
Yeah.
So these macrophages are just randomly present in the alveoli, right?
Yeah.
This is not a true respiratory bronchiole. So for that reason, I don't think that respiratory bronchiolitis is that great of a term. It's not always in the respiratory bronchiole. And even if this one is, let's say there's an artery on the left side and you say that one is, there are macrophages away from it too.
Yeah.
In the surrounding alveoli. So I feel that, that's one problem with respiratory bronchiolitis. The other problem is that it makes you think there's an itis.
Agree.
And many trainees at least feel that itis means lymphocytes. So they're looking for inflammation in the bronchioles. They're looking for inflammation of the kind we think is inflammation, right? Great. Now, interestingly, if you talk to a clinician, they'll say, well, macrophages are inflammatory cells, right? And I go, yes. He says, then it's an itis. It's an alveolitis. Or I say, well, yes, you're right, theoretically speaking, but that's not how pathologists look at it. Yeah. You cannot show a pathologist a bunch of macrophages and say, well, that's an itis, isn't it? Most pathologists will say, no, you show me lymphocytes, plasma cells, neutrophils, right? Then I'll call it an itis, but not with macrophages alone. So for those reasons, Matt, I don't think this is a great term. And that's why I've switched. Even respiratory bronchiolitis, I've stopped using it. But I acknowledge many people would call this emphysema and respiratory bronchiolitis. So let me flip the question to you. How would you diagnose this case?
I actually don't tend to use respiratory bronchiolitis either very much. I don't think it's a very good term. So I think I would be descriptive of this as well and just highlight that there's pigmented alveolar macrophages.
So we are all three on the same page.
Yeah. Consensus.
Consensus.
Our kappa is perfect so far.
Now all you need to disrupt the consensus is bring in a radiologist. Okay.
So the radiology with the reticulations, do you think it just wasn't sampled in this case?
Sorry?
So the because this patient had some reticulation on radiology. Do you think it just wasn't sampled well in this?
Probably.
Yeah.
Because I don't see any fibrosis or the biopsy is so good. I think it's not sample.
Cool.
And that's all for this case. I think emphysema with airspace pigmented macrophages.
So Irene, can I ask you a question? When you signed the case out like that, emphysema plus pigmented airspace macrophages, are your clinicians okay with that? They understand what you're saying?
Yes.
They understand, right? Okay. They're okay with that terminology, right?
Yes, they are okay with that terminology because I think they normally have a question, just like, is it due to smoking or is it due to something else? Then if I say whatever I say, they just cross the box. It's smoking. And
okay. Got it. Yeah.
I saw here, I forgot to tell about some like fibroblast plaques here.
Yes.
It happens sometimes for no specific reason, but I've seen sometimes in smokers also they have many pneumonias and things, and sometimes there are some random fibroblastic foci.
Yes, I was going to say that, there's no reason that this person couldn't have a very mild organizing pneumonia on top of the smoking related changes. It's just very minimal in this biopsy, right? Not enough to really say much.
Yeah.
But I don't think you would be wrong to say, focal minimal organizing pneumonia.
I say in the micro description, I make a micro description with all the things I find, and then I make a diagnosis with the thing that I find more relevant.
Right.
And that maybe would be maybe I would put it in the diagnosis like the second thing or something.
Yeah. I think we're all in agreement, which is very rare.
Cool.
In non-neoplastic lung.
Well, should we move to the second?
Yes, go ahead.
Yeah.
Then I have a patient that I called number 3. He's a male and he's 55 years old. He's a smoker also, and he has an interstitial pneumopathy that it's under study. The CT shows a not UIP pattern because they see air trapping, and they perform the cryobiopsy because of suspecting respiratory bronchiolitis versus HP. I was dubious because I just realized that I put my diagnosis and I didn't want to show it to you, but it's okay.
Yes. And just for the audience,
patients are the pneumologists suspect chronic HP here versus
smoking. And just to explain to the audience, because maybe some residents might be watching this and people who don't do interstitial lung disease daily, that this is a very common differential diagnosis. Like radiologists feel strongly that if they see centrilobular nodules and air trapping and some bilateral ground glass opacities, that the two main things in the differential is smoking related disease, especially RBILD or respiratory bronchiolitis, interstitial lung disease. And the second differential would be HP, which is hypersensitivity pneumonitis. So this is a very widely, accepted differential in the radiologic world. And it seems like the histology is different enough that you should be easily able to tell those two apart, right? Because RBILD has nothing in common with HP on the histologic level. Agreed, Irene? Did I say that fine?
Yes.
Okay.
I think we lost your screen sharing there.
Yes. Yeah. 1 second.
Okay.
Just correcting something. Now it's here again.
Perfect.
Yeah.
Great.
Then this is the cryobiopsy again. I always choose the other one was better, had more parenchyma, but this one is not bad. I always go to see first the one that looks with more parenchyma, not airway. And this would be my favorite. The first. It's also a big piece, not as big as the other one. It's a big. In this case, compared to the other one,
oh wow,
you can see that interstitium is thickened. Clearly thickened. It's not normal.
It's a beautiful case, actually.
Yeah.
Here is normal. Here is almost normal, and everybody would agree that the rest is not normal.
Yeah.
What in the interstitium? Well, there is collagen for sure. And this collagen has a ropey look.
Yep.
Maybe. I say chewing gum, but I have this. I discussed this with Sanjay before. He doesn't see the chewing gum at all. And this is one thing. There are some cells also, but
So what kind of chewing gum, Irene? Is that the chewing gum after you have chewed it?
yes, it's like the ball that you
The
have.
ball. Oh, I see. Yeah. Now I get it.
Strawberry chewing gum when you have to chew it and spit it. That's the look. But I see the rope now. After talking about, I can see the rope. What I don't see, what we don't see, is our uroblastic foci or so. Then another thing that we see is that the alveoli are enlarged, and again, in this biopsy we can see much better the pigment.
Yeah, we're losing your audio, I think, a little bit, Irene.
Yes.
Can you just say this again? What is this finding, what you're showing now?
The alveoli are enlarged, and then we see the airspace macrophages again.
Yeah.
We can see it better here than the pigment, the color, the golden color,
Yeah.
how fine it is, and the little dots.
Little dots.
It's very nice.
That's perfect. That's absolute. And also, Irene, do you want to just for our audience explain why this is not HP?
Well, in HP, I wouldn't expect to see this kind of fibrosis. I would expect to see more inflammation, and I would expect to find little giant cells or groups of giant cells in the interstitium and distribution around the airways.
Correct. Yeah. Absolutely right. So can you bring it to slightly higher mag, Irene, to in the same place where you had it before, but higher mag? Yeah.
I have more.
So Matt, now let me ask you, because this is a perfect case.
Yeah.
Now I ask you, what would you like to call it?
So I tend not to bottom line it as SRIF. I tend to be descriptive, and so I would highlight again the pigmented alveolar macrophages. I would describe the interstitial fibrosis with the ropey appearance, and then make a comment that this is likely smoking related. I think my biggest differential on this field would be as NSIP, but I think it's a little bit too patchy for me to call NSIP. I think there's areas of really normal looking lung even in this field. And so I think that would be my differential would be between an NSIP versus kind of smoking related fibrosis.
Do you think this is a good fit for RBILD, Matt, from the histology?
So I tend not to use the term RBILD either, but to me, I think that's more of it's less of the interstitium that's involved. Yeah. I think that if I was going to predominantly characterize this, the main abnormality is mainly in the interstitium. And I think the pigmented alveolar macrophages are a lesser component.
Yeah, in fact, many of them almost don't have any, right? Like you on the left-hand side of the field, at about 9 o'clock, you have a very significant macrophage accumulation there where Irene is pointing to, but the rest of it is kind of, there are a few macrophages. It's certainly not DIP level filling, right? Correct?
I agree completely. So I don't
correct diagnosis here.
Yeah.
There's too much fibrosis for RBILD. In fact,
correct,
many people, including the person who described RBILD, which is Dr. Katzenstein, would say that you should not have any fibrosis in RBILD. Or how she worded it was no significant fibrosis, which is the same thing. You shouldn't have. So this particular case would not fit with either one. Right. So people who would describe and leave it to the clinician would say is that, well, now if it's basal predominant ground glass opacities and the patient is sick, this is DIP. And if it's upper lobe centrilobular nodules and ground glass, that's an RBILD. But I would say, but histologically, this is wrong for both. This is wrong for both of them. And let me make another point is about the really good point you brought up about NSIP. That's a really, really good point. Is before we had SRIF and the ropey collagen that Irene was talking about, we didn't even have a way to distinguish NSIP from DIP, right? DIP versus NSIP. And like you said, Matt, before we were talking, is that some people would say if it's more diffuse, that's better for NSIP. If it's more patchy, it's better for DIP. but we never had the concept that the morphology of the fibrosis helps you,
Yes.
right? That the ropiness is actually a characteristic of smoking related fibrosis, and you don't get that in NSIP. NSIP is a much more a sort of a different kind of fibrosis, doesn't have the ropey look, and is mixed in with lymphocytes throughout. So, this thing, just the fact that you have an entity named SRIF gives you a way to, think differently about these diffuse fibrosis cases. And now you're able to say, I'm sure this is a smoking related fibrosis. This is not NSIP. And so then the final issue becomes, well, there is no entity named SRIF clinically. And I think that's where you have a point, Matt, is that we don't have a clinical entity named SRIF, although we have a pathologic entity named SRIF. And that's where the problem lies. That's where we need some buy-in from clinicians to say, well, look, this is also clinically a better term to give these patients. So I will concede that we are trying to bring a new entity into the clinical realm.
Yeah.
And so I agree with you on that, Matt. But histologically, I would say that this is that smoking related interstitial fibrosis is a far better term for this, what's going on here, than either RBILD or DIP.
I agree with you completely. I think my only concern is that you can see both SRIF in pathologic processes and as well as a background finding in smokers. And so that's the challenge I find with that diagnostic term is it describing a disease state, or is it describing a background finding in just the fact that this is a smoker, in the same way that the pigmented alveolar macrophages, or RB, is just a feature that you see in smokers.
Correct.
Not really a disease state.
Yes.
And I think in this case, in this patient, is this SRIF what is causing their abnormalities on their CT, or is this just part of their background lung changes?
Yes, and that's perfectly valid. And I would say that that's the same problem we've always had with RB and RBILD, right? We say there's a lot of RB here. Is this what's causing the patient's problems? And there's no way to tell, right? You go back to the clinician and then they make a judgment on that and they call it RBILD. The problem is, like, you have RB and RBILD, you don't have an SRIF and an SRIF ILD,
Mm-hmm.
At least in the current situation. Maybe it needs some sort of a reimagining of the clinical terminology for these diseases too.
Yeah, I agree completely. I think if there's a diagnostic term that took this histologic pattern in conjugation with the radiology and the clinical impression, I think that would be really useful, because then you could then put it together, right? In a similar way that we take the UIP pattern with the clinical and radiological and it becomes IPF, right? Could you take this SRIF pattern with the clinical and radiological and turn it into some defined disease entity?
Yes, that's correct. Irene, any thoughts about, like, how do you, when you bottom line it like that as SRIF, you do, right? Like, you put it on your reports now?
In this case, I called it SRIF. I didn't used to do it before. I just was descriptive, but since we published the paper, I'm being more bold with this, because I want also to make
this. And Irene is a co-author on that paper. Does it show up right?
Yeah, it shows perfect. Yeah, I have it printed as well, so I could get all my talking points down of.
That's the paper she's talking about. Yes. So then, what happens, Irene? Do you get your clinicians saying, "Well, can you tell RBILD or DIP?"
I would like to know if this is what happens when they suspect DIP, that if it's SRIF really. But I think the main problem to make these things meet is that we also see this in cancer specimens.
Yes.
And they don't have an interstitial disease. Then we again have something, a pathological diagnosis that happens when there is a clinical disease and when there is not.
Yes, which is the same thing Matt is saying, right? He's saying the same thing. How can you have an incidental and a disease both with the same finding? And what I'm saying is, why is it any different than RB? We deal with the same thing with RB, right? We said when it's just RB and incidental, it's RB, and when it's associated with clinical symptoms, it's RBILD. right? So what we need is a term that is corresponds to RBILD for SRIF.
Yeah.
That's what we need.
I think a counterpoint too is that I think some people would consider the pathologic form of RB as being DIP, right? When you have expansion and complete filling of the alveolar spaces by these pigmented alveolar macrophages, that's when histologically it enters into a disease state and it's characterized by DIP, right? And so
yes, but I would say, Matt, just to counter that, is that even DIP is not always, so when you see it histologically, it's not always clinically significant.
Agree.
We see that all the time in pneumothorax specimens, for example.
Yep.
Have tons and tons of alveolar macrophages. That is classic DIP by any definition. And then you look clinically, there's nothing going on. It's just a pneumothorax case with no interstitial disease, no symptoms.
I agree completely. I think that that diagnosis really requires a clinical pathological correlation, is that you have to look at the imaging and the history and make sure that it fits, because I think there's a spectrum of that.
Yeah, this is a great case, Irene. This is really,
it really is, yeah.
I just wanted to show you that in other fragments, it looked much more patchy than.
Yes. Yes.
And for me, SRIF, it's the patchiness, no, compared to, for they make it the differential with NSIP, it's more patchy, the SRIF, and the quality of the fibrosis is different. This ropiness, and this fragment has not much.
Yeah.
In terms of treatment of these patients, they'll basically just suggest smoking cessation for these SRF patients.
Yes. Yes, Matt, because we don't really know in the long term what happens with these, especially when they present as an ILD. And the interesting thing is, so can we talk for 1 second about DIP RBILD treatment? Because that's one of my favorite topics also. So as you know, for many years, this has been the rationale for this differentiation, right? They said DIP is a steroid responsive disease and RBILD is not a steroid responsive disease. So it's smoking cessation for RBILD and steroid therapy for DIP. And actually, if you look at the literature, and that's all in our paper, we've put, we put a detailed review of this. The best study, I think, by far is from J. Rue's group from Mayo Clinic. J. Rue, Myers, Capizzi, Vassallo, those people, Decker, Paul Decker. And that paper from 2005 actually has a beautiful definition of DIP, which is missing in all the other prior papers. Filling of the thing at 40x versus not filling. Jeff Myers was the pathologist, so a good pulmonary pathologist looking at these cases. And then they gave some of them steroids, right? So guess which one responded better to steroids, DIP or RBILD?
I think it's RBILD, right?
RBILD had a better response to steroids. Now, if you think of saying a disease is steroid responsive, Matt, what percentage of cases would you want to respond?
Well, probably 80 to 90% in an ideal world.
90%, right? That's reasonable. You know how many responded in this series?
I think it was pretty low, right?
33% was the best. 33%.
Yeah.
On CT evidence of response to corticosteroid. Wouldn't you also want to know that response happened only because of steroids, not because of smoking cessation? But that wasn't the case. These people also stopped smoking.
Yeah.
So we don't know anything about this. We don't know that DIP is more steroid responsive than RBILD. Mm-hmm. Only about 1/3 of DIP respond, at most. Only about 1/3 of DIP respond, and that response might be confounded by smoking cessation, because smoking cessation also causes improvements. And finally, if you read that paper, they say the improvements were transient in those cases. So almost all cases where the PFTs improved, they went back to the baseline, and so there was no improvement at the end of the day. So I think this idea that DIP responds to steroids, especially for smokers, is completely backwards. It's not, there's very, very little proof that is actually the case. So we might say, well, there's no data for SRIF, but there isn't that great data for RBILD or DIP either.
Agree.
And if you consider that many things that in the past were called DIP could now be called SRIF, I would think they would respond the same way. They would have some transient response to steroids, but it would go back to normal. That you should tell them to stop smoking, right? You should tell any smoker to stop smoking. And then you can't expect this thing to go completely back to normal even after smoking cessation, because there is fibrosis, there's emphysema, there's macrophages. I don't think that these patients can be completely cured, with anything.
Yeah, I agree completely. I think any lung disease that's characterized by this degree of fibrosis is never going to really go back to normal. You're not going to get rid of that dense fibrosis.
Yeah. Irene, what do you think about the treatment part, about SRIF and then DIP and smoking and steroids? What are your thoughts about that?
Well, I completely agree. I think the concern of the neurologist is why, well, to differentiate which of these patients are going to behave better or worse. They see that some, they say stop smoking and some get a little bit better and some not. And I think we have to study more in this field. But the first thing that we need to study more is to have bold terminology. If we don't know if some of us are calling DIP something that has fibrosis in the interstitium, and some we are calling different things the same name and different names the same thing, it's impossible to find out or to investigate.
Agree. All right, perfect case. You got another one, Irene? Okay.
Yes, it's the fourth patient. It's a female, 56 years old. She's a smoker. She's referred to our hospital as a transplant candidate. These are a nightmare because I don't have much information on these patients. And the CT says it's not UIP, and they see bilateral ground glass. They send me the surgical biopsy,
which was done somewhere else, Irene? So
somewhere else.
Okay.
And the suspicion is NSIP versus DIP. I have two pieces of this. Oh, sorry.
Hey, I also realized with these cases that we all agree it's not UIP, which is a great thing in lung pathology.
Or maybe this one. I don't know. Well, we can begin with this one. These are 3 sections of this lung. Doesn't look much worse than my cryobiopsies. And we see, I don't know the localization of the biopsy. What happens frequently when you get at this consult. Well, listen to me. I see a piece of lung here that seems pretty ill.
Yep.
With fibrosis in the interstitium, with site hyperplasia or activity.
Yes.
Alveoli full of macrophages that are not that pigmented.
Yeah.
Some other inflammatory cells.
But the interstitium, Irene, can we see the interstitium one more time? Is pretty thick, right?
It's very thick, yeah.
Pretty thick.
Very thick.
And it does have some ropey collagen at least to the bottom left, I can see here. Correct? Has some ropey collagen.
But it has, but it's not as clear as, it's not as clear as in the previous case, and I'm not used to see this.
Type 2 pneumocyte hyperplasia?
Mm-hmm.
Hyperplasia.
Yeah.
In SRIF. Well, the macrophages, I don't think that I don't remember if I saw or not urolast foci. I don't think so.
No. And Irene, would you agree that this is also a bit emphysematous or no? I think it looks emphysematous at low. Like
I don't know if
at the bottom of the field.
Emphysema or.
Matt, what do you think about the emphysema? Does that?
Yeah, I think it's hard to say. I find a lot of these, but I wouldn't disagree that there's some emphysema here. But I think I'd also correlate with the CT scan.
Mm-hmm.
Massive.
Yeah, massive. Yep.
But the interstitium is not okay.
Mm-hmm.
And this one, maybe here I see fibrosis, but I don't think it's honeycomb. But
No.
Right. Me neither.
It's very uniform process I'm finding.
Yes. Mm-hmm.
and we can see the other. And the
Interesting.
piece that looks a bit different. I don't know if it's
Yeah.
from a different area,
Yeah.
but
Actually, that if it is the same patient, this is a great teaching point also.
Yeah.
the same.
Say, hey, look, there's DIP on that one, and hey, there's completely normal lung on this one. It doesn't make any sense. That's another reason, Matt, that I don't like this thing, is you could go from one field to another on the same piece of lung.
Yeah.
And say that's completely normal lung in one field, RBILD in the next field, and DIP in the next field over that. That's why this whole thing just does not make any, conceptually, it doesn't make any sense. But anyway, Irene, back to you, sorry.
This is more similar to the other one. Maybe it's better inflated, but similar to the other one. We see thick interstitium. We see these macrophages. This interstitium still thickened with macrophages here, but I wouldn't say massive here. Here again the same, and I think there was a piece where it was almost normal here.
Interesting.
The is just congested, and it's almost normal. What do you want to call this biopsy?
Yeah, let's give it to Matt. What do you want to call this, Matt?
Wow.
I
Okay.
have no answer.
Yeah, I think this is a really challenging one. And so to me, that first area you showed, I think there was too much fibrosis for me to just call it SRIF. And, you know, I agree that there was a bit of collagenous appearance to it, but the fibrosis didn't look like this piece here I could believe as SRIF, but the first one you showed I think is beyond that. And then I really think there's a fibrotic ILD going on. I think it's too patchy for me to call NSIP, at least in this area, taking the whole thing in together. But that first one you showed, I don't think it was bad for NSIP. I think that the one also had too much fibrosis to call DIP. So yes, there was macrophages expanding the alveolar spaces, but I think the degree of fibrosis was beyond what I'll accept for DIP. So I think ultimately I'd probably be descriptive in this one and explain it, but I would put some important things like I don't see features of UIP, so I don't see honeycomb change. I don't see temporal heterogeneity. I don't see features of hypersensitivity pneumonitis, so there's no giant cells or granulomas. And it's a bit of a patchy process, which kind of excludes NSIP to a degree. And so I think I'd probably be more unclassified.
Yeah, I think that's an understatement, actually, Matt. So, Irene, if you just stop here for a second, I think this interstitium is so normal that I mean, NSIP would be a complete blunder to call it here.
Oh, I agree, yeah.
In this field, right? And if you agree, I mean, you have to agree with the concept that NSIP has to be diffuse everywhere, right?
Yeah.
That there really shouldn't be any significant normal lung in between. If you agree with that concept, then this cannot be NSIP.
Agree.
That's completely out. And I think all three of us agree it's not UIP, right? Correct? We are on the same page. So Irene, do you agree that it's not NSIP?
I had doubts about it. I mean,
So you will call NSIP even if some of the interstitium is normal?
Yes, but when I have this kind of cases, I sometimes try to look at, oh, normal, is it normal? But well, I have to agree that this looks really normal. But as it was mostly uniform, I thought that the thing that would fit better would be NSA.
Oh, I see. Okay, now I understand. Yes, so if you
But
allow
I agree
normal
totally that this is
NSIP,
not
then you could call
the
this NSIP.
real definition of NSIP.
Depends on what you call NSIP, right? So for me, any amount of normal makes it out of NSIP. I mean, especially this much normal. This is like completely.
Mm.
And then on the left hand side, what you're showing is, to me, classic smoking related changes. You've got you've got emphysema, you've got collections of
Yeah.
pigment macrophages, and you've got this. It's not perfect ropey, so I agree with you, Irene, on that. It's not a classic case like the first one, but it does have a little bit of ropey collagen, and it has also this sort of smooth muscle hyperplasia that's very common in these smoking related things. So of the choices that we have, I would rather call this smoking related something, and I mean, honestly, in my practice, I would probably call this SRIF.
That's right. Yeah.
Yeah, I would.
Even with the first slide there that Irene showed,
Even with
that
the first slide, Matt. So regardless of how much fibrosis there is, that doesn't factor into my, uh,
okay.
and so that's the great thing about SRIF, is
Mm.
it depends almost purely upon those three things being present: emphysema, the ropey collagen, and the macrophages. And it doesn't make a difference how many macrophages or how much fibrosis. You see what I'm saying, Matt? So in my
Yeah.
calculation, how much of it is present doesn't matter, and how much of the macrophages are present also doesn't matter. Like, it all gets subsumed under that
Mm.
umbrella, which is
Uh,
broader than most people would think.
Yeah, I guess the challenge I find with that is then the how broad the term is then, right? Is that, we span from the first case we saw, which was really just kind of mild incidental findings, to something here that's causing significant fibrosis, and the
Yes,
patient's a transplant candidate, right?
yes.
Um, and how useful is that term then if it spans such a large disease process from the trivial to needing a transplant?
Yes, so let me ask you, Matt. You've seen emphysema transplant cases, right? And like,
That's correct. Yeah, yeah, yeah.
so pure emphysema alone, without any fibrosis, commonly comes to transplant when
Yeah.
it's end stage. So why would you not have in the background insignificant RB, SRIF, all kinds of other smoking related changes? Why do we have to? Why does SRIF have to be the explainer of the clinical situation? Is what I'm asking. Why couldn't the
Mm.
clinical situation be mainly because of the emphysema and maybe a little bit of contribution from the fibrosis?
I guess in this case, if I don't know if we can go back to the first slide that you had there, but I think that degree of fibrosis was
Significant,
pretty significant, and I think that could explain a lot of what is potentially driving what's going on.
right?
Um, and this, I think I would be in an NSIP spectrum just considering this slide on its own. I agree. I don't make that diagnosis if there's large areas of normal lung, but
This is an old biopsy. It's 2014 that
okay.
I received this case. At that time, I remember I struggled really with this biopsy. It came with the diagnosis of DIP,
Mm.
and I didn't want to say DIP because I have already read that I couldn't do that. But I was like switching from one of these pieces to the other and saying, here I see NSIP, here I see normal lung. What should I call this? And I found this case the other day, and I thought that nowadays I would call it SRIF.
Mm.
Despite it's not perfect, and that's why I wanted to brought this case.
Yes, I think this is a perfect case, because it shows you that all of us would approach it differently.
Mm.
And we come at it from a slightly different angle. And I think it is a difficult case, and I think it does bring up how you define something makes a difference, right? Like how you define NSIP, how you define SRIF, how broad you keep it, and then to what extent you want the clinical picture to be explained by the macrophage accumulation, by the fibrosis. So I think we can leave it there. We don't have to agree on this. I think it's fair to just see it from different points of view and explain why this is a difficult case.
And I think what we do agree on is that there is a big smoking related component in this case. I think that's,
Yeah.
well, we all agree, but we'll all call the fish different things, but we all agree that it's a
True.
fish, right?
Although, Matt, I would say, like, if you are going to call this NSIP, then that's not really a smoking-related disease. I don't think anybody sees it as a smoking.
No, I wouldn't call it NSIP. I guess I was just saying that some of these areas are NSIP-like.
Yeah.
In,
And I
in,
was telling you, Matt, like in the old days, I won't name the place, but there was a certain place where this was a uh, differential. Like this was a standard differential. They said, is this DIP or is it NSIP in a smoker? Like
Yeah.
that would come up every day in sign out. They look at a case like this, say, is this DIP or NSIP in a smoker? DIP or NSIP in a smoker? Now I think all of those were SRIF. All of those were SRIF. And now, you know, that we just, it just, I think the problem is the mental shift from
Mhm.
having two categories to now having a third one where you go, well, where did this come from? And just to bring that analogy that I brought up before to you, Matt, like in a world where there was only a dog and a cat, you had to say dog, cat, dog, cat. And sometimes you would fit things in between and you say, well, I think this is more like a dog than a cat.
Mm.
And now you have a raccoon. And now you go, well, I want to call it a raccoon, but the clinicians don't have a term that corresponds to that. But now you see that everything that you were forcing into dog or cat was actually a raccoon. So that's what's happening in my mind, Matt. You know, like I'm
Yeah.
seeing all these raccoons now, and they say, well, but there's no term for the clinicians for that. And I say, well, tough luck. It is a raccoon.
Yeah, I agree with you completely. And I guess the other thing I consider is what is biologically going on here, right? And that I think there's a fundamentally different biologic process in some of these, right? Like in this case, when we have all these accumulation of these macrophages, and they don't, and they often in these DIP-like areas, they don't really have the nice pigment, right? And so, why is the body responding by all these macrophages accumulating? And
Mm.
I think that there's something fundamentally going on different at a biological level that's reflecting all these macrophage accumulation. I agree the term DIP is not great, but I think this observation is important. And I think that this is potentially reflecting something different that's going on. And yes, steroids might not treat this well, but as we understand this more, I think there's something to be gained here, that these might be different, and there might be a way to target these in a different way with all these new immunomodulatory agents than just shotgun steroids or things like that, right? And so and that's why I still think there's value in the DIP term and thinking about this, because this is different than what is described in SRIF. This accumulation and filling with these macrophages, I think, reflects something that's going on at a fundamental biological level.
They say there is like DIP like DIP areas or DIP like areas or
Yes.
something.
Yes. So that, Matt, that actually in the original SRIF paper, there are three or four cases like that
Yeah.
of the DIP like, which is exactly what you're describing. You know, those are cases like this.
Yeah.
Where you would say, well, this is fundamentally something different because there's so many macrophages accumulating here. But if you just back up, so Irene, if you just go to low mag now on this case, just go to the lowest possible mag. And there is another piece here, right? Oh no, that's the second piece from the. So I would ask you, Matt, why is there something biologically so distinct in one piece and not in the other piece? Is it that part of the lung is responding in that biologically distinct way and that part of it is not?
I don't think we understand that, and it's something that I've always struggled with too. Is why is DIP lower lobe predominant, right? Most smoking related disease is actually upper lobe predominant,
Yes,
right?
exactly.
And I've asked that to a number of radiologists, and I've never got a good answer. And to me, I actually think that is important. I think that's an important clue.
Yes.
That I think there's something biologically going on different in a true DIP case.
Yes.
That the lower lobe predominance is not just from inhaling something, because you would expect to see the opposite pattern. And so
Right.
I think there's a precedence for why it's patchy. And maybe this is upper lobe sampling, right? And maybe the other one, because we don't know what this is, and the other one's lower lobe, right? And it's showing a lower lobe predominance, right?
Yeah.
In the same way as why is UIP a lower lobe predominant disease, right? I don't think we have a great explanation for that, but I think there's a different biologic process going on, whether there's some abnormality in macrophage signaling or something that causes these to all to, because they must be proliferating. They're filling these spaces and
Yeah.
expanding them, right? So
Yes.
I think there's something going on there, and I think we'll eventually sort that out of what's going on, and I think it's different than the SRIF, which is really an interstitial process
Right.
that it can be from the repetitive injury from smoking, and then you get a scarring, and that's why it has that collagenous appearance.
Right.
But I would argue that this is something different than that.
So can I make another, I can make a case that we all three are in agreement with one more thing. Can I make a case for that?
Please.
So we are all three of us are in agreement that emphysema is a smoking related finding in most patients, right?
Yes.
Are we in agreement? Second, we are in agreement that this kind of macrophage proliferation of whatever degree of pigmented macrophages happens in smokers. That's quite a distinctive thing. We agree with all three of us?
I agree that the majority are, but I think you can see DIP-like changes in non-smokers as well.
Correct.
Like the series will show that there's some people have occupational things or
Yes.
other reasons for accumulation of macrophages.
Yep.
And I think that makes another reason why it's not just a smoking-related thing, DIP.
True. Correct. Correct. No, that I totally agree with that. But what I'm saying is, so if you flip it around and look only at smokers,
yep,
that accumulation of macrophages in their airspace is a characteristic thing that happens in them, right?
Agree.
Whatever name you give it to it.
Yep. Agree. Yeah.
And then the third thing I think we will all agree is that this kind of ropey alveolar septal thickening is quite characteristic of what happens in smokers. Is another smoking related finding. Would you agree with that?
Agree.
Right. And now and this is not quite in the literature yet, but I have a paper that's in process right now where we looked at about 600 lung cases, all resections, right? So lobectomy, pneumonectomy, explant, surgical lung biopsies, all resections. And then we blinded them. So my resident took the slide, took off the sticker and put a random number on it.
Okay.
And then they mixed them all up. So now I don't know which one is which, right? They were just consecutive cases over many, many months, maybe 3 years. Then mixed it up and gave it to me and said, what's the diagnosis here? So I had to pick SRIF, emphysema only, RB only, mixture of those things, no smoking related findings. Okay. So there were 68. So I don't know anything about the patient. I don't know what kind of specimen it was. Is it a smoker or not? Was it a lung cancer case or not? ILD? I know nothing except I have a slide in my hand.
Okay.
So it's a purely blinded histologic diagnosis. So of those 600 cases, I called 68 of them SRIF.
Okay.
Can you guess how many were smokers of those?
68.
68.
Yeah.
Okay, so it gives you, there's something there, Matt. I mean, the finding has some specificity.
Agree.
Which is not actually is better than the specificity for RB or even for emphysema. In fact, we have data in that study for the specificity of those two, which is lower. So there is something about that kind of fibrosis that is quite specific for smokers. And even if we don't agree on terminology, at least we should agree on that principle that that finding is a smoking related finding. Maybe we can agree on that.
I agree completely with that definition of SRIF. And
Irene, I mean, you really made us discuss the whole spectrum of this disease. Thank you so much.